Hi, y'all, and welcome to Professor Truelove's Concepts for Nurses series. I am Professor Terry Truelove, and in this episode, we continue our discussions of atrial dysrhythmia in Atrial Rhythms Part 2, where we will discuss atrial flutter and atrial fibrillation. Sources for this episode include Cohn's Flip&See EKG, 4th edition. As discussed in Part 1, many of the atrial rhythms can lead to more serious atrial rhythms. This is one of them, atrial flutter. The strip demonstrated here represents classic atrial flutter. In this case, we have a 2-to-1 ratio, that is, 2 of the little flutter waves versus 1 QRS. Don't be confused because atrial flutter is a type of supraventricular tachycardia. This is because the origin of the impulse comes from above the ventricles, but we don't necessarily call it an SVT. It's characterized by an atrial rate of between 250 and 350 beats per minute, although it's generally around 300 beats per minute. It originates from a single atrial focus, and this rhythm results from circuit reentry and possibly increased automaticity. On an EKG, the P waves lose their distinction due to the rapid atrial rate. The waves blend together in a sawtooth appearance and are called flutter waves, or F waves. Flutter waves are the hallmark of atrial flutter. What predisposes a person to atrial flutter? Well, atrial flutter is commonly associated with second-degree heart block. In that instance, the AV node fails to allow conduction of all the impulses to the ventricles. As a result, the ventricular rate is slower. Atrial flutter is commonly found in patients with severe mitral valve disease, hyperthyroidism, pericardial disease, and primary myocardial disease. The rhythm is also sometimes encountered in patients after cardiac surgery or in patients with acute MI, chronic obstructive pulmonary disease, COPD, and systemic arterial hypoxia. Atrial flutter rarely occurs in healthy people. When it does, it may indicate intrinsic cardiac disease. Atrial flutter may be caused by conditions that enlarge atrial tissue and elevate atrial pressures. The clinical significance of atrial flutter is determined by the number of impulses conducted through the node, expressed as a conduction ratio, for example, 2-to-1 or 4-to-1, and the resulting ventricular rate. If the ventricular rate is too slow, that is, fewer than 40 beats per minute, or too fast, more than 150 beats per minute, cardiac output can be seriously compromised. Usually, the faster the ventricular rate, the more dangerous the arrhythmia is. The rapid rate reduces ventricular filling time and coronary perfusion, which can cause angina, heart failure, pulmonary edema, hypotension, and syncope. On your rhythm strip, atrial flutter is characterized by abnormal P waves that produce a sawtooth appearance, the hallmark flutter wave appearance. Varying degrees of AV block produce ventricular rates 1/2 to 1/4 of the atrial rate. Think of the AV node as a gatekeeper or doorman. Sometimes it lets atrial impulses through to the ventricles regularly, that is, every other impulse. But sometimes it lets them through irregularly. For instance, 2 impulses might get through, then 3, and then 1. AV node usually won't accept more than 180 impulses per minute and allows every second, third, or fourth impulse to be conducted, the ratio which determines the ventricular rate. You need to be careful with this rhythm because it can be sneaky. Pulses may be normal and the patient may be asymptomatic, especially if the ventricular rate is between 60 and 100 beats per minute. However, the patient may become symptomatic if the ventricular rate becomes less than 60, that is a slow ventricular response, or more than 100, that is with a rapid ventricular response. Patients who are symptomatic are called hemodynamically unstable. Treat unstable patients for the ventricular rate. If the ventricular rate is less than 60, treat like a symptomatic bradycardia and consider things like a pacemaker. If the ventricular rate is greater than 100, treat it like a symptomatic tachycardia. Consider synchronized cardioversion. Medications are not the first intervention because they actually might make the problem worse. Medications are used after the patient is asymptomatic. Another common atrial dysrhythmia is called atrial fibrillation. This is associated with atrial fibrosis and loss of muscle mass. It is common in heart disease such as hypertension, heart failure, and coronary artery disease. In atrial fibrillation, because of the loss of atrial kick, cardiac output can decrease as much as 20 to 30%. The rhythm strip on this side shows the characteristic regularly irregular rhythm that is associated with atrial fibrillation. In other words, there is no set pattern that can be discerned in each one of those R to R intervals. AFib is by nature chaotic and asynchronous. The electrical activity in the atrial tissue is completely disorganized. AFib is the most common cardiac arrhythmia. In AFib, there are multiple sources of impulses in the atria and in the re-entry pathways that are all striving to be the pacemaker of the heart. The ventricles respond only to those impulses that make it through the AV node, similar to the mechanism described for atrial flutter. When you review this rhythm on your monitor or graph paper, you will find that atrial activity is no longer represented by P waves, but instead by erratic baseline waves called fibrillatory waves or F waves. Atrial fibrillation may be either sustained or paroxysmal, that is, occurring in bursts. Irregular conduction of impulses through the AV node produces a characteristic irregular ventricular response. Causes of AFib include cardiac surgery, prolonged hypotension, pulmonary embolism, chronic obstructive pulmonary disease, electrolyte imbalances, heart valve defects, thyroid gland abnormalities, and acute myocardial infarctions. Other causes include infection, coronary artery disease, hypoxia, atrial septal defects, and atrial fibrillation can be found in healthy people because of the effects of things like caffeine, alcohol, nicotine, fatigue, and stress. A word here about atrial kick. Since the atria are quivering, the atria do not contract all at once and do not help to fill the ventricles. This means that the ventricles do not get to fill completely. This has a direct effect on stroke volume and is tolerated poorly in people with cardiac disease, because this can lead to cardiovascular collapse, and it also can lead to clotting abnormalities, including thrombus and emboli. On the rhythm strip, look for the absence of P waves and an irregular ventricular response. Multiple ectopic sites mean depolarization is unorganized. Remember that the AV node protects the ventricles from the 400 to 600 erratic atrial impulses that occur each minute by acting as a filter and blocking some of the impulses. If the muscle tissue around the AV node is in refractory state, impulses from other areas of the atria can't reach the AV node. When describing atrial fibrillation, you need to include the ventricular response. So, for ventricular rates less than 60, it is customary to say the patient is in AFib with a slow ventricular response, or AFib with SVR. If the ventricular rate is greater than 60 but less than 100, the rate is simply referred to as atrial fibrillation, or AFib. If the ventricular rate is greater than 100, we refer to the rhythm as AFib with RVR, or atrial fibrillation with a rapid ventricular response. Remember, treat symptomatic patients for bradyarrhythmias or tachyarrhythmias, not for the atrial fibrillation. Also note that the apical rate may be different than the peripheral pulse rate. Overall, you need to control the rate in AFib using medications or even cardioversion. Because of the possibility of stagnant blood in the atria, anticoagulant therapy is indicated to reduce the risk of a thrombic or embolic stroke. Other interventions for patient-centered collaborative care for atrial fibrillation include reducing the risk for pulmonary embolism and venous thromboembolism by using anticoagulant medications. Other interventions include the use of antidysrhythmic drugs, cardioversion, percutaneous radiofrequency catheter ablation, the Maze procedure, and biventricular pacing. The Maze procedure uses scarring around the area of the conduction to create a maze that the impulses must pass through. This is similar to ablation, which basically both cause scar tissue to make it more difficult for the impulse to travel from cell to cell. With biventricular pacing, an artificial device takes over the role of the pacemaker, and therefore the rate of the ventricles can be easily controlled by a machine. Now we have come to the end of yet another episode, but hang in there. There's more episodes coming about junctional and ventricular rhythms. In the meantime, I hope you learned a little something today. I hope you're coming back, and if you are, we'll see you then.